morning. Well, I think we are on the last leg of the cataract session. I think with this, today I think I'm going to finish up the cataract topic. And from Monday onwards, I think we will have glaucoma. I'm going to take glaucoma from Monday. After the glaucoma is also over, you will have an examination on both these topics. So I'm telling you well in advance, and please kindly get prepared. Read and try to write it. Maybe this we may consider for internal assessment marks. Okay. So we have already seen almost all the topics in the lens chapter, except for congenital cataract and also the congenital anomalies of the lens. Okay, so congenital cataract actually it forms when the lens formation is disturbed during the intrauterine life. So usually the classification, it involves the embryonic nucleus and fetal nucleus. And the developmental cataract actually, it is from the infancy to the puberty or adolescence. So the infantile nucleus and also adult nucleus will be involved in case of the developmental cataract, and the fibers which form prior to and later to the stage of disturbance, they remain clear and normal. Okay. So congenital cataract actually it occurs about 3 out of 10,000 live births, and as I have already told you, it is due to the disturbance in the formation of the lens during the particular period. The lens fibers which are being formed at the particular period, when there is a disturbance in the lens formation, those fibers only will become actually opacified, and the rest of the fibers prior to the disturbance and after the disturbance, they may remain clear and normal. Okay. So the disturbances in the lens formation prior to the birth is called congenital cataract. And opacity is restricted to the embryonic nucleus and also the fetal nucleus. Developmental cataract actually, as I have already mentioned, it's from infancy to the adolescence, and fibers being formed at the time of disturbance, they are affected, and the fibers which were formed prior to the disturbance and after the disturbance, they remain normal and clear. So usually the congenital cataract shape, they are genetically transmitted with genetic mutation, and usually it is autosomal dominant. And the other reasons could be for congenital cataract formation. It can be chromosomal abnormalities, such as we see in the case of Down syndrome, and in metabolic disorders, galactosemia and parathyroid dysfunction, and all these things can occur. And intrauterine infections such as rubella, cytomegalovirus infection, herpes, all these things actually, they can give rise to actually cataract formation in the children. So if you take etiology, about 33% of the cases, they are idiopathic, where we cannot identify any cause or reason for it. And about 1/3 cases of the total number of cases is hereditary. So inherited cases without systemic disorders, they get transmitted by autosomal dominant inheritance. And inherited cases with systemic disorders, so we have the example, trisomy 21, Stickler syndrome, cerebro-oculofacial syndrome, and Loeys syndrome. Okay, these are the various conditions which actually occur, which are inherited with systemic disorders. So common familial cataracts are cataracta pulverulenta, zonular cataract, and coronary cataract, and total cataract. Okay. And there are certain maternal factors which contributes to the formation of a congenital cataract, such as the malnutrition of the mother during the pregnancy. It can give rise to actually a cataract formation, congenital cataract formation. And infections of the mother during the pregnancy with rubella, toxoplasmosis, and cytomegalic inclusion disease. All these things, they result in congenital cataract, especially rubella occurring in in the first trimester, second to fourth week of the pregnancy. It can give rise to actually a congenital cataract. And suppose if the mother takes certain tablets, medication during the pregnancy, such as thalidomide and steroids, so she can actually, the child can be born with a congenital cataract. And if suppose mother is exposed to radiation during the pregnancy, then also the child may be born with a congenital cataract. So there are certain fetal factors or infantile factors which can give rise to the cataract formation. The first and foremost is a deficient oxygenation due to a placental hemorrhage during placenta previa or abruptio placentae. So these cases, actually, the patient may be having a deficient oxygenation, and that can give rise to actually a cataract formation in the newborn. So birth trauma. So maybe forceps delivery, the flanks of the forceps may hit actually the ocular structures, and that can give rise to a birth trauma, can give rise to a cataract formation, an infantile cataract can occur. And metabolic disorders such as metabolic disorders in the child, such as galactosemia, galactokinase deficiency, and neonatal hypoglycemia. These are the things which can give rise to a cataract formation. So there are certain associated the internet connection unstable and వస్తుంది. Internet connection unstable and flashing. అవతల వాళ్ళకి వినిపిస్తుందా లేదో తెలియదు, ఎవరు ఏం కంప్లైంట్ చేయలేమని. Certain anomalies are associated with the congenital cataract. So the congenital anomalies such as Lewis syndrome and myotonia dystrophica and congenital ichthyosis, so they are sometimes associated with a congenital cataract. And there are certain ocular diseases which are also associated with congenital cataract, such as a persistent hyperplastic primary vitreous, aniridia, that is absence of the iris, and anterior chamber cleavage syndrome, and retinopathy of prematurity, which occurs in the newborn when they are exposed to a lot of oxygenation. Oxygenation in premature children actually it occurs, and underweight children. And posterior lenticonus is another complication, is there another congenital condition which may be associated with congenital cataract. And microphthalmos is another condition actually which is associated with the congenital cataract. So there are certain types of actually clinical types of congenital cataracts. So one is an anterior capsular cataract. Anterior capsular cataract, it is a thickened opacity in the center, and it is non-axial, stationary. Visually, actually, it is insignificant. And posterior capsular cataract, actually, it is a rare one, and it can be associated with persistent hyaloid artery remnants. So anterior polar cataract actually is another thing which is commonly seen, and it is due to a delayed development of the anterior chamber. And secondly, it can be because of the corneal perforation in case of congenital, in case of ophthalmia neonatal. Okay, so the corneal perforation, whenever the cornea gets perforated because of ophthalmia neonatal, in ophthalmia neonatal, the cornea, the anterior capsule comes and touches the back of the cornea, and that can give rise to actually an anterior polar cataract. So, okay, so anterior polar cataract is these are the two causes actually for anterior polar cataract. There are again three types. One is, we'll come to that later. Congenital nuclear cataracts are there, and cataracta pulverulenta is one, lamellar cataract is another, and sutural axial cataract. Number అక్కడ ఇదే
మాట్లాడుతున్నాం మనంతా బాగానే ఉందని వాడు చెప్తున్నాడు. పిన్ నెంబర్ అడిగాడు, నీకు పూర్తిగా ఇస్తున్నాను వాడు చెప్తున్నాడు. మరి ఇక్కడ మా క్లాస్ లో ఉంది చూడమని చెప్తున్నాడు, చూస్తున్నాడు. ఎందుకంటే సేమ్ లో అప్పుడు వచ్చింది,
అక్కడ కూడా వచ్చింది.
మళ్ళీ మీకు చెప్తాను.
Respect for the chair. Well, the third one is actually sutural and axial cataracts. Under this head, we have floriform cataract, coralliform cataract, spear-shaped cataract, and anterior axonal embryonal cataract, and dendritic cataract. And the fourth one is actually total cataract. And next we have generalized cataracts. So coronary, blue dot, total congenital, and congenital membranous cataract. So the morphological types are, in case of anterior capsular cataract, it can be actually a thickened white plaque in the center of the anterior capsule. And usually it is insignificant and the vision is not impaired. So anterior pyramidal cataract is a cone-shaped cataract and affects towards the cornea. So this also actually, it will not interfere much with the vision, and the patients, they are unaware of actually the opacities unless they are examined. In the routine examination, we see actually there is an anterior pyramidal cataract. Okay, and sometimes it progresses and gives rise to some disturbance in the vision also. So reduplicated cataract is another thing. When there is an anterior thickened white plaque, the lens fibers which are beneath this thickened white plaque, they can also get opacified. And as the time goes on, there will be transparent fibers which will be laid between the thickened white plaque and also the cortical fibers which are already opacified. So that the pushing actually the cortical fibers which are opacified underneath, and it will be an imprint of the thickened white opaque capsular opacity. So both put together, it will be a reduplicated cataract. Okay. So reduplicated cataract, actually, I think it can be given as a short notes question for you people, maybe two marks question. And posterior polar cataract is another thing which is quite common, and it is associated with posterior hyaloid artery remnants or Mittendorf's dot. And posterior lenticonus is another thing which can be associated with the posterior polar cataract. And persistent hyperplastic primary vitreous is another thing which actually is associated with posterior polar cataract. Posterior polar cataract, actually, it is a thick, circumscribed opacity in the posterior polar region, and the vision is usually much affected in these people. And as it progresses further, congenital nuclear cataracts, you have cataract centralis pulverulenta, lamellar cataract, and sutural and axial cataract, total nuclear cataract. So cataract centralis pulverulenta, actually it is autosomal dominant inheritance is there, and central embryonic nucleus, actually it is affected, and the disease progresses and the patient will have, the child will have, will be born with actually an embryonic cataract in the newborn. And since the central opacity will be powdery, in the powdery form will be there, and that's why it is called actually pulverulenta. Lamellar cataract or jonular cataract, actually it is important for you people. It will be given as a short notes, and it is seen actually, the opacity is seen in fetal, infantile nucleus. There are various causes for this lamellar or jonular cataract, and first and foremost is it can be inherited autosomal dominant inheritance is there. And rubella infection in the first trimester of the pregnancy can give rise to actually lamellar cataract or jonular cataract, or environmental factors such as vitamin D deficiency and also hypocalcemia. All these things actually they can give rise to lamellar cataract or jonular cataract, and it is associated with the rubella syndrome sometimes. With the fundus, you have actually a salt and pepper appearance of the fundus will be there, and there can be a microcornea and persistent hyperplastic primary vitreous. All these things that can occur. Sutural and axial cataracts actually, so the opacification is the dots will be present in the anterior bisutures and also posterior bisutures of the lens. And total nuclear cataract, actually these people they are born with actually fairly white cataract opacities, lenticular opacities, and the whole the embryonic nucleus, fetal nucleus, and also infantile nucleus and cortical matter, so they are all affected, and the vision will be impaired in these cases, and they will have to take care of it in the immediately after birth. So not immediately after birth, maybe as early as possible. So generalized cataracts, actually you have coronary cataract. Here we have club-shaped opacities in the axial region, hundreds of club-shaped opacities will be there. And blue dot cataract is there. And another total congenital cataract is present, where actually there will be whitish opacity in the lens, and almost all the say you have the membrane of nucleus, fetal nucleus, infantile nucleus, and to a certain amount the cortical matter, all these things they will be affected. And membranous cataract is another thing actually, where the newborn itself, what will happen is actually there will be lenticular opacity, the cortical matter actually they may get liquefied, and it is a congenital lens matter gets liquefied, and you see actually we may mistake it as for actually congenital aphakia, because there is no nucleus, cortical matter is completely liquefied and absent, and a thin membrane actually will be left in the pupillary area, and it is an aphakic condition, and we may think actually it's a congenital aphakia. Okay, rubellar cataract actually is another thing which is very, very important. It may be given as short notes for you people. Here actually the infantile nucleus will be affected, and the child will be born. There will be history of actual infection, rubella infection in the first trimester of the pregnancy, and the cortical matter may get liquefied, and it's a congenital, look like actually a congenital Morgagnia nucleus. And when you examine actually the fundus will be a salt and pepper appearance of the fundus will be seen. And rubella syndrome actually is another condition where actually you have the rubella cataract will be there, and the associated congenital malformations will be there can be persistent hyperplastic primary vitreous, microphthalmos can be there, and posterior lenticonus can also be seen in these cases. And the patient may have actually deafness, so destruction of organ of Corti is also present in these cases, and organ of Corti will be there, and the cardiovascular anomalies such as ventricular septal defect, patent ductus arteriosus, all these things can be present in rubella syndrome. Rubella syndrome and rubella cataract, they can be given as short note questions for you, maybe a 4 marks question or sometimes 2 marks question. In unilateral congenital cataract, cause is not clear, and only in about 10% of them cause can be explained. Unilateral cataracts are usually sporadic without any family history or systemic disease. And full-term healthy babies, they may be born with a unilateral cataract changes. And persistent anterior fetal vasculature may be associated commonly in unilateral cataracts and congenital cataracts. So all these things we have seen already. So this is a blue dot or punctate cataract, and this is lamellar cataract or jonular cataract actually. So this circular opacity which is present actually in the cortical area, and sometimes two such things will be there, and there can be riders from this opacity in case of jonular cataract. So this is again the diagrammatic representation of morphological shapes of cataracts. So posterior subcapsular, coronary, peripheral, and anterior subcapsular, pyramidal, nuclear, lamellar, okay, posterior polar cataract. So morphology of cataract is congenital cataract is very, very important, which indicates actually the possibility of the etiology and the its effect on vision. So nuclear cataract, actually opacity is confined to either embryonic cataract, embryonic nucleus or fetal nucleus, or sometimes infantile nucleus, and the dense opacity, or it may look like dust-like opacities. So lamellar cataract, actually opacity affects both anterior and posterior lamellae, occurs in infants with a metabolic disorder or uterine infection with rubella or cytomegalo-inclusion disease, herpes simplex, all these things. And coronary, as I have mentioned already, opacity in deep cortex surrounds the nucleus, and its club-shaped opacities will be there. Blue dot opacities are common, can associate with other types of cataracts. And here again, it's a coronary cataract with by oblique illumination, and it is with the slit lamp by a microscope optical section. Anterior polar, we have already seen. Posterior polar, we have already talked about. Membranous cataract, I told you that it's a rare one. The nuclear cortical matter completely gets absorbed, and a thin membrane will be left behind actually in the pupillary region, which we mistake actually for a congenital aphakia. Many systemic pediatric conditions are also associated with some congenital cataract. Sometimes the first and foremost is there can be metabolic conditions which are associated with congenital cataract, such as a galactosemia. And here the appearance of the cataract will be like a central oil droplet lens opacity will be seen, and it develops in the first few weeks of life. And oculocerebrorenal or Loeys syndrome, and it is a unilateral cataract, and microphakia, posterior lenticornis and capsular cataract can also be present in this. And hypoparathyrroidism is another condition which can be associated with congenital cataract. Hypoglycemia or hyperglycemia, sometimes it may be associated with the cataract formation. And intrauterine infections, I have already mentioned congenital rubella. The virus persists normally within up to 2 to 3 years in the lens after birth. Other intrauterine infections such as toxoplasmosis, herpes simplex, and varicella can cause neonatal cataract. Chromosomal abnormalities, trisomy 21, all these things can give rise to skeletal syndromes. Cataract with the microphthalmos can occur, Stickler syndrome, and all these things. And this is actually again congenital cataract. This is nucleus cataracta pulverulenta, so powdery-like appearance. And the second one is actually a lamellar cataract. And the third one is a dense lamellar cataract with riders, jonular cataract with riders. And this is actually a coronary cataract. So these are also a punctate dots. Okay. And this punctate blue dot cataract cerulean also, it is its name is, and you see these opacities. And again, you have central pulverulent cataract, a diagrammatic representation of this. So management of congenital cataract, actually, the ocular examination is very, very important. You'll have to see for any other abnormalities associated with the cataract, such as a posterior hilar remnant, or sometimes associated with lenticonus, anterior lenticonus or posterior lenticonus, persistent hyperplastic primary vitreous, persistent pupillary membranes, microphthalmas. All these things, they may be associated with actually the congenital cataract. And second thing is, actually, whenever you do an ocular examination, you are supposed to make out the morphology of the cataract and also the density of the cortical cataract, density of the cataract, so that gives you actually the rather an impression regarding the vision the patient is still having. Okay. And the thing is, actually, the vision of the individual to assess it in the newborn or in the infant, it is very, very difficult. So we come to a conclusion on seeing the morphology of the cataract, lenticular opacity, and also the density of the lenticular opacity. The density of the lenticular opacity is assessed by doing a distant direct ophthalmoscope, so through which actually we can see the fundal glow. If the fundal glow is actually not really good, that indicates that the density of the lenticular opacity is very, very high. Okay, and next, what we have is actually to assess the vision. Suppose the child is having vision or doesn't have vision, you can as well assess with the morphology and density of the lenticular opacity. Second thing is optokinetic nystagmus is another thing which and visually evoked potentials is another test we do actually to know it. And forced fixation reflex, if it is present or not, that also we see. And we try to focus a light and see whether the child is actually following the light. Okay, so that's another way actually we see whether to know whether the patient is having vision or not. And the systemic investigations which we do before actually operating the cataract are, and these are torch tests for rubella, toxoplasmosis, herpes, and all these things we try to do with this thing. Urine analysis for reducing substances, and galactosemia and Lewis syndrome for amino acids in the urine, and fasting blood sugar will have to be done to know if there is any hypoglycemia or hyperglycemia, and better refer the case to the pediatrician to see whether there are any other associated anomalies. Okay, so management of congenital cataract, according to the bilateral density of the cataract, it requires surgery when the child is around 4 to 6 weeks to prevent amblyopia. So amblyopia is the management of amblyopia in pediatric cataracts is always a uphill task. So unless we properly manage it, the patient is going to have a subnormal vision. So if the amblyopia sets in, even if we do actually the management of amblyopia, the child will not have actually a satisfactory vision. So most of the cases, normally we try to operate them if they are clinically significant, the opacities, when the child is around 4 to 6 weeks. If the opacity is asymmetrical, one side actually has got a denser opacity and compared to the other eye, the denser opacity or advanced eye will be operated first, will be dealt first. And bilateral partial opacities, surgery can be delayed in case actually the patient is having reasonably sufficient vision. Usually the child's activities are at hand stretch. Okay, so if there are thin bilateral lenticular opacities, I think we can as well leave them because it's not going to cause any problem or cause any amblyopia in the near future, because there won't be a deprivation amblyopia in these cases because the light passes through whatever remaining the lenticular lens which is clear. Okay, so it can be operated when the child attains more than 2 years. Okay, unilateral dense cataracts, they require surgery as early as possible, immediately within days. And anti-amblyopic therapy should be instituted by giving the child an opaque glasses or contact lenses And you will have to take into confidence the parents' support also, because those people, they will have to put the contact lenses and remove it. And nowadays, actually, we are not leaving the eye phakic. In any case, we are trying to put actually an IOL depending upon actually the age of the individuals. We take certain precautions to correct it to the proper age. Okay, if detected after 16 weeks, actually the cataract, a dense cataract, since the fixation reflex actually it occurs in 2 to 3 weeks. Okay, in the intraocular life. So these people, the surgery may not be of much use. And partial unilateral measures to prevent amblyopia will have to be instituted. And detailed history is important actually regarding antenatal history, the type of delivery and all these things. If there is any forceps gel delivery, which may reflect actually an injury to the trauma in the immediate during the delivery. All these things you will have to take a detailed history. If there is any evidence of rubella infection in the first trimester of the pregnancy, or malnutrition, or any history of placenta previa or epilepsy of placenta, all these things actually you will have to elicit prior to actually coming to conclusion. Clinical evaluation and laboratory by slit lamp. We have handheld slit lamps. With an oblique illumination also we can come properly, reasonably we can assess the morphology and density of the lenticular opacity, where exactly it is, whether it is confined to the embryonic nucleus, fetal nucleus, or infantile nucleus, whether cortical matters are involved, whether it is an anterior polar cataract, anterior capsular cataract, posterior capsular cataract. All these things actually we can assess with a clinical examination by oblique illumination. Laboratory tests I have already mentioned. We'll have to get done the urine test for sodium nitroprusside test for any amino acids or anything, and reducing substances, red blood cell reductase levels. All these things actually will have to make a note, and have serum calcium and phosphate and X-ray skull will have to be done in certain cases wherever it is needed. And blood sugar levels is also important to know whether the patient is actually having hyperglycemia or hypoglycemia. And IOP will also be will have to be taken by Perkins appellation tonometer, and fundus examination by after full dilatation of the pupil will have to be done. So in case of rubella syndrome or rubella cataract, we may find actually salt and pepper type of retina, and there is retinopathy of prematurity, retinoblastoma. All these things actually we can make out in the newborn in case when we do the fundus examination. And a B scan ultrasonography to rule out a retinal detachment and retinoblastoma will also will have to be done. A scan to measure actual intraocular pressure. A scan, sorry. Sir, I'll call you back in the class level. So A scan will have to be done to actually to measure the IOL power calculation, and the retinoscopy for partial cataracts actually it can be done, and if a correction is needed, we try to put in actually cataract glasses. Assessment of the density of the cataract is utmost important. That gives actually the urgency of doing the cataract surgery, and timing of surgery and surgical techniques and type of optical rehabilitation. All these things will come to it later. And the differential diagnosis in case of congenital cataract, one will have to keep in mind. One is a retinopathy of prematurity, retinoblastoma is another, and persistent hyperplastic primary vitreous is another thing, and toxocara endophthalmitis is another condition which is to be differentiated from the congenital cataract, any opacity in the white pupil, leukocoria. So these are all actually the various differential diagnostic conditions which will have to rule out from congenital cataract. So the treatment is not indicated unless the vision is considerably impaired. So we can examine the patient, undilated fundus, and also after full mydriasis. And lamellar cataracts, usually 1 year or 2 years after the birth, actually we come to it. Complete, suppose if the total congenital cataract with complete pearly white opacity, if it is not operated actually at the correct time, the patient may have actually a squint, that is an exotropia or an nystagmus. If the fixation reflex is interfered with, the patient will have an nystagmus, to and fro, continuous to and fro movements of the eyeball can occur. Unilateral cataracts, normally they should be operated within 6 weeks. And suppose if we leave the eye aphakic, in such conditions actually we'll have to put in a contact lens or prescribe actually the spectacles to the individual. And critical period is when the fixation reflex actually occurs. So suppose if we don't operate prior to the in second 2 and 4 months of the age, actually the patient may develop actually visual deprivation, amblyopia. So one will have to be careful. And use of contact lenses, one must take into confidence the parents' cooperation, because the child cannot put the contact lenses by themselves. Nowadays, actually, we are not rather keeping hopes on these contact lenses or opaque glasses. And we are trying to actually do an extracapsular cataract extraction, lens aspiration from with the phaco, and then put in actually an IOL. So these are the 3 procedures normally described in the textbooks. So the decision to insert an IOL, it all depends on the age of the child and also the laterality of the cataract, whether it's unilateral or bilateral cataracts. And surgeon's assessment of family's ability to look after the child in the immediate post-operative period, and also as their ability to take care of the child from going amblyopic. IOL is preferred when the child is more than 2 years, and especially unilateral cataracts or even bilateral cataracts. IOL material is normally previously it used to be a polymethyl methacrylate. Nowadays, actually, we have better materials, Acrysoft lenses and all these things, foldable lenses we are putting it. And it's a single piece IOL, and the diameter normally it is around 12 millimeters. AC lenses, we never put it actually in the children. It is discontinued. Maybe it was done previously. And IOL power calculation will have to be done. And suppose if the child is more than 8 years, by which time actually the eye has completely developed, we rather try to put in an emmetropic power lens. Okay, so between 2 and 8 years, 90% of that required for emmetropia, the power of the lens should be 90% of that power required for emmetropia that we will implant. And if the child is less than 2 years, 80% of that required for emmetropia, that power of the lens will be of that power, and that we try to implant into it. Okay, the post-operative management, the visual recovery, this post-operative, these people actually, the congenital cataracts, the inflammation, post-operative inflammation will be more in these patients, and especially in rubella cataract, since the virus, it stays in the lens up to 2 years after the birth. So when we do actually cataract surgery, when we remove the nucleus, there can be liberation of this virus also, and can give rise to a lot of inflammation, and sometimes may result in an endophthalmitis also. So that's very, very difficult. And this rubella infection, actually, it can be prevented. The vaccine is toxic to the fetus. So the mother will have to be given the vaccine if she 3 months prior to expected date, 3 months prior to the pregnancy actually. So if she plans pregnancy, say 3 months or 6 months from now onwards, she can as well take actually rubella vaccine, so that there will not be any problem of rubella infection in intrauterine. And secondly, it will not be toxic to, it will not affect, the vaccine will not affect the fetus. Okay. Treatment of amblyoptic complications will have to be done. These people, they will have to, suppose if one eye is affected and the other eye is not affected. Nowadays, previously we used to do actually leave-it-aphakia if the child is less than 2 years, especially in a dense unilateral cataract. We used to remove it, and we never used to put in actually an IOL. That was some 2 or 3 decades back, not now. Then the people, they may go in for actually, there is a risk of amblyopia occurring in the particular child. So that's the reason actually we used to give them either aphakic glasses or a contact lenses. And we used to request actually the parents also to take care of the child. And the post-operative astigmatism is seen, and fibrinous uveitis is very common actually in case of pediatric cataracts. So steroids is the mainstay of treatment actually in fibrinous uveitis. And secondary glaucoma can also be seen actually in case of congenital cataract, anti-glaucoma medication, and lens optic capsule because of chronic uveitis, which is induced by post-operative inflammations and all these things. So it can occur. So what we do is we try to dilate the pupil and constrict it just behind the lens, over the lens. So that may take care of lens optic capsule. Otherwise, it causes constant irritation to the iris and gives rise to continuous inflammation of the iris and problems to the child. And displacement of the lens, sometimes it occurs. And posterior capsular opacification is almost seen in almost all the cases. Cystoid macular edema is another complication which can occur in congenital or developmental cataracts. And retinal detachment is another condition which can occur in congenital cataract. So posterior capsular opacity, so when the child actually becomes sufficiently big enough to sit before actually the slit lamp by a microscope, then we try to do it with the eye laser. Otherwise, suppose if it is obstructing the vision, we can as well do a posterior capsulotomy surgically, either with a cystosome or with a J-glass knife. And secondary membrane in the pupillary region can also occur, and that can we will have to do a membranectomy. And proliferation of lens epithelium onto the posterior surface of the cornea can also occur. Proliferation of lens epithelium onto the posterior capsule can give rise to a posterior capsular opacity also. And a glaucoma and retinal detachment, these two things can also occur, which we have already seen. Visual rehabilitation, previously it used to be with spectacles and contact lenses when we did not put in an IOL. Nowadays, actually, we have good type of IOLs, and we can as well put in an IOL with a newborn. Suppose if there is a bilateral thick lenticular opacity, in such cases we do it first one eye as early as possible, and the second eye within 2 to 3 days after the first eye also will do it. So congenital and developmental anomalies of the lens is also another thing which normally we may not actually ask you in the examination, but it's for completion side actually I'm telling you. With or without other anomalies, malformations of the lens. Abnormal shape or size, coloboma of the lens is one thing actually. So notch shape defect usually in the inferior margin. This is okay, and a defective development of part of suspensory ligaments of jonules of chin also will be there. So cataract here is associated with anterior persistent hyperplastic primary vitreous, persistent hyperplastic primary vitreous, and persistent hyaloid artery with a stalk issuing from the optic disc will also occur. The posterior capsule of the lens gets invaded by the fibrovascular membrane, which contracts and eventually leading to elongation of the ciliary process. And eye is usually microphthalmic, and you'll have to differentiate this from retinoblastoma, retrolental fibroplasia. And second one is a conjunctal ectopia lentis. 8 pupillae which we have already seen in displacement of the lenses. Lenticonus, the cone-shaped elevation of the anterior lenticonus or posterior lenticonus holes of the lens. So this can give rise to some problems. Lenticonus anterior normally is associated with Alport syndrome, and lenticonus posterior is associated with Loeys syndrome. And distant direct ophthalmoscopy, when you do a distant direct ophthalmoscopy in these individuals, there will be oil globule appearance in the center of the red reflex, and congenital cataract can occur. And spirophakia, microspirophakia of the lens, all these things that occur. Here actually the lens is spherical and smaller, and usually associated with the Weil-Mattresani syndrome. And lenticonus, abnormal curvature of the conical curvature, lenticonus anterior and posterior. Posterior is seen with the Alport syndrome. Microspirophakia, lens is spherical and small and can occur as an isolated condition or as a feature of Weil-Mattresani syndrome and Marfan syndrome. So here is microphakia, and here again anterior lenticonus, posterior lenticonus, and microphakia again, and posterior lenticonus. And ectopia lentis, we have already seen it. So that completes actually the topic of lens. So in the examination, we keep all these instruments in the afternoon in the Viva, and we ask you what they are and where they are used. This is actually a crescent blade, which is used actually for doing a corneoscleral channel. Okay, and this is actually a keratome with which we enter at follow clock, and this is the side port blade, and this is again a crescent blade, which is used actually in small incision cataract surgery. This is McPherson forceps, and this is actually a cystotome. This is a hydrodissection cannula, and this is actually visco cannula. These things will definitely show you again, and this is our dialer. This is an irrigating vectis with which actually we remove the nucleus in case of small incision cataract surgery. So all these things we have seen, and that completes actually the topic of lens. If you have any doubts, you can ask me. If you have no doubts, I think we call it a day. It's already 9:45, and the next person is in wait, taking the class of somebody else. I don't know who it is.